In a patient who has a BRAF mutation and initiates dabrafenib trametinib as frontline therapy to target that mutation, second-line therapy is multiple options and really becomes clinically dependent. What's going on with this patient at the time? Unfortunately, we see that a high percentage of patients who initiate targeted therapy towards BRAF subsequently develop brain metastasis as their first site of progression. In that context, then radiation is likely a component to your treatment, and we have to think about whether or not steroids are involved, and that then decides can you use immunotherapy eventually, et cetera. In a patient who has low volume metastasis or progression, probably we would use a monotherapy PD-1 agent, but if a patient had massive progression, you might then go to a combination immunotherapy, ipilimumab plus nivolumab, again in the context of do you need to do radiation concurrently or before that therapy, and does the patient require steroids? So there are multiple immunotherapy options that certainly would be considered a standard, and it sort of goes to what's going on with this patient at that moment.